Welcome back to 12 Days in March. In this section, we will cover the key pulmonary tumors you need to know for the Step 1 exam. The tumors are classified as small cell and everything else. This classification derives from the treatment implications of each tumor, with small cell not being curable by surgery. Note that adenocarcinoma is most common. That type of information doesn't generally excite me, but occasionally there will be a question where adenocarcinoma is the answer simply because it is most common. We won't cover large cell in any detail, as these are less common overall and rarely tested as they lack meaningful derivatives. That is, large cell tumors are essentially a diagnosis of exclusion. They lack glandular features of adenocarcinoma, lack squamous differentiation, and they lack the immunohistochemical staining features of small cell carcinoma. Lacking features hardly makes for great test fodder. Bronchial carcinoid is also covered at the end of this presentation. Mesothelioma is covered with asbestos in the pneumoconiosis section. In the remainder of this section, we will focus on the key distinguishing features of each of these tumors and also look at common complications of lung cancer in general, all of which make up the majority of the NBME test materials. Insofar as the history is concerned, headline news: smoking causes lung cancer. The way the NBME uses smoking in the lung cancer questions is opposite of the conventional wisdom. They like to ask about lung cancer in the non-smoker. Which is most likely? Answer: adenocarcinoma. The physical exam is useful for complications such as obstruction as well as paraneoplastic phenomena. It doesn't tell us much about the tumor per se. The issue of central versus peripheral is bantered around the review manuals. It is less relevant for the NBME as tumors can be found in either location. In fact, it seems they use this information for purposes of deceit. That is, they will describe a classic squamous cell, for instance, but in a peripheral site. Folks lose their mind and won't choose it because it's supposed to be central. Don't get wed to this association of central versus peripheral. It is unlikely to be a deal breaker in an NBME question. So here is the meat of the topic. You need to know the pathologic descriptions, especially for small cell and squamous cell. This is the language. They won't say a patient has squamous cell, for instance. They will bury the diagnosis in keratinization and intercellular bridges. We'll cover this shortly. Secondly, they use the paraneoplastic syndromes as the key distinguishing feature. Students are generally aware of these associations, but they struggle to actually make the diagnosis. For instance, most students know that small cell cancer is associated with SIADH, but when presented with serum sodium and urine osms, they decompensate. In this presentation, I won't just list the syndromes. You will learn about them in the appropriate context. And finally, complications of tumors, such as pleural effusions, are a rich source of questions for the NBME. We'll cover this material as well. So, with that background, let's launch into the tumors. The focus again is distinguishing features. Please note the title box with two useful notes. First, I use the older traditional name of oat cell carcinoma. This pretty much describes the pathology in small cell. This cell resembles oats, or might be described with a lymphocyte-like appearance. Secondly, molecular genetics reveal the presence of an LMYC mutation, with the L conveniently linking it to the lung. This is a gain-of-function mutation with increased gene transcription leading to cell proliferation. As far as key background information, it is considered a centrally located tumor associated with tobacco use. Don't waste brain space on this information. It is the cell of origin that is the money with small cell carcinoma. Neuroendocrine cells are the characteristic cell. This is the key as it explains the paraneoplastic phenomenon seen with small cell. Specifically, these tumors release endocrine products, including ACTH and ADH, that become the major focus of inquiry. The neuroendocrine cells also have characteristic histochemical protein markers, including enolase, chromogranin, and synaptophysin. When these are described in pathology specimens, you are being told the patient has a neuroendocrine tumor. There is no requirement to know what these peptides do, they're just listed for completeness. On pathology, you'll note small round cells with scant cytoplasm and dark nuclei, which sound very much like a lymphocyte. Neurosecretory granules may be described. But here is the money. Small cell is totally about the paraneoplastic syndromes. Eaton-Lambert is most straightforward, with antibodies forming against the presynaptic voltage-gated calcium channel. Compare and contrast that with myasthenia gravis, where antibodies form against the acetylcholine receptor. Increasing the amount of acetylcholine with a cholinesterase inhibitor such as tensilon or idurfonium will result in improvement in motor function in patients with myasthenia, but not in Eaton-Lambert. In Eaton-Lambert, the defect is the presynaptic channel. Tensilon has no effect as acetylcholine is not released into the synapse. Next in the queue is SIADH and ectopic ACTH. These come with a warning. The warning is this: small cell carcinoma is a neuroendocrine tumor. SIADH and ectopic ACTH are endocrinopathies. Next up is a pragmatic review. If you are unfamiliar with the content, either grin and bear it or just fast forward. But do note, you will eventually need to become familiar with this material. So let us proceed. The syndrome of inappropriate antidiuretic hormone, called SIADH, is reviewed in detail in the renal section. It took a lot of restraint for this presentation, and I've restricted the discussion to 3 take-home points. These include: the diagnosis is established if the patient is hyponatremic, that is, there's a low serum sodium. They must be euvolemic, defined by a normal effective circulating volume, and the urine osms are inappropriately concentrated. These are the defining characteristics of SIADH. And here are the qualifying comments. Hyponatremia is a disease of free water excess. We'll clarify that in a moment. Euvolemia means there is neither need nor desire to hold on to that free water. I thought need nor desire sounded poetic. The bottom line is you have a normal, effective circulating volume. You don't need ADH and you don't need free water. For our body to correct hyponatremia, it should dump free water, creating a maximally dilute urine. If the sodium is low and the volume is normal, get rid of that water. We need to fix the hyponatremia, and this is fixed by dumping water. Dumping water dilutes the urine a lot. In SIADH, however, the urine is not dilute. I actually prefer to call this the syndrome of inappropriately concentrated urine. So why is there an excess of free water? A quick review of ADH will get us there. So what does ADH do? It manages water. Really, that's all it does. How does it manage water? ADH binds to a G-linked protein receptor, inducing the synthesis of the aquaporin channel. Aquaporin, which is a great name, a pore for aqua, inserts into the tubular lumen apical surface of the principal cell. Voila! Water is absorbed. Through this process, ADH regulates plasma osms. The principal osmolyte in that plasma osm is sodium, so simply doubling the sodium gives you a good approximation of the plasma osmolarity, as BUN and glucose only contribute marginally to the P osms. In SIADH, the process is dysregulated. You can see the excess ADH here, leading to excess water absorption. The excess water absorption generates hyponatremia. We went from a plasma sodium of 140, which is normal, to now having a plasma sodium of 125, which is markedly decreased. So my second condition requires the presence of euvolemia. That means the kidneys are happy. They are being perfused adequately. If they weren't adequately perfused, they would stimulate the release of ADH via angiotensin II. In that case, we refer to ADH release as the non-osmotic release of ADH, and it is appropriate. That is, the kidneys are thirsty. The same applies for the peripheral baroreceptors. If the patient is hypotensive due to volume depletion, the baroreceptors would stimulate ADH release, and once again, it would be appropriate. So for the syndrome of inappropriate ADH release, by definition, euvolemia must be present. This will be designated in your vignettes by normal blood pressure and/or pulse. That is, there is nothing driving the release of ADH. And the third condition necessary for the diagnosis of SIADH is the inappropriate concentration of the urine osms. Under normal circumstances, when presented with a serum sodium of 125 and a euvolemic state, the hypothalamic osmoreceptors would normally suppress ADH release. No water would be resorbed, and the urine would be maximally dilute in the range of 50 to 100 milliosms per kilogram. In this syndrome of inappropriate ADH release, in spite of normal volume and the low sodium, the kidney is avidly holding on to water and perpetuating the hyponatremia. This is inappropriate and very naughty. The urine osms are inappropriately elevated or concentrated. That's very dumb. And that's a quick tour of SIADH for small cell carcinoma. Hyponatremia, euvolemia, and inappropriately concentrated urine characterized by a high urine osm. We can see how the NBME plays the SIADH game with these questions. The first scenario is a smoker with weakness and fatigue. The blood pressure is normal, i.e. they are euvolemic. A chest x-ray notes a mass and the serum sodium is decreased at 120. This is the language of small cell. So what is the pathology? Small dark cells that look like oats or lymphocytes. Histochemical stains? This ain't Prussian blue, folks. Look for enolase, chromogranin, or synaptophysin. The second scenario, we have a smoker with a p-osm of 240. They give the p-osm instead of a serum sodium. That's tricky. The serum sodium is essentially half of the p-osm, so the sodium would be 120. Once you make that connection, then they hit you with a urine osm. In a patient with a serum sodium of 120, the urine osm of 280 is not maximally dilute. So what's the diagnosis? This is SIADH. And that was a fun little journey through the SIADH game. SIADH is the toughest of all the paraneoplastic syndromes. By comparison, the rest of this section should be a breeze. Okay, let's knock off ectopic ACTH. Ectopic ACTH means high ACTH. The only other meaningful cause of high ACTH besides ectopic secretion is a pituitary adenoma, also known as Cushing's disease. So your challenge will be to distinguish between these two syndromes, ectopic production or a pituitary adenoma. Before sorting out the distinction, it is important to first identify the high ACTH state. So high ACTH leads to high cortisol, assuming the patient has normal adrenal glands. Both ectopic and pituitary adenoma patients will present with Cushing's syndrome, that is, signs and symptoms of Cushing's. I list the presenting symptoms, including central obesity, hypertension, striae, and hyperpigmentation. We'll come back to hyperpigmentation shortly. The data will also reveal hyperglycemia, low potassium, high bicarb, as elevated cortisol behaves like aldosterone. That is, hyperaldosteronism will give you metabolic alkalosis with low potassium, high bicarb, and hypertension. Hypercortisolism will do the same thing. Both the ACTH and cortisol will be elevated, but that's just to distinguish the high ACTH from a scenario with adrenal failure where cortisol is not being synthesized. So the definitive study for the NBME is the provocative test, the high-dose dexamethasone suppression test. Be aware, this is a functional assay used to distinguish between the adenoma and ectopic source. To be sure, this is the language of ectopic ACTH production. They use the high-dose dexamethasone suppression test result to cue you in to ectopic production. So the patient will be established with a high ACTH and cortisol. They are given a high dose of dexamethasone, which is an exogenous corticosteroid. Think about the response. If you are a heavily mutated tumor who is independently secreting an ectopic hormone, do you really think it will be suppressed? Really? Small cell carcinoma is a nasty player. An adenoma, on the other hand, is screwed up for sure, but much less mutated. And here are the results as predicted. In ectopic production, neither ACTH nor cortisol suppress. A pituitary adenoma, on the other hand, will partially suppress. And that's how they'll do ectopic ACTH in a patient with small cell carcinoma. Just a quick word on that hyperpigmentation. ACTH does have homology with melanostimulating hormone MSH. As such, it can bind the MSH receptor and cause hyperpigmentation. This is a low-yield fact, but I've seen it buried in some of the more challenging questions. And finally, for small cell, let's see how they play the ectopic ACTH game. Here we have a smoker with weakness and fatigue, physical exam with elevated blood pressure, buccal mucosa with pigmented macules, i.e. hyperpigmented. The labs reveal a high glucose, a low potassium. Chest x-ray has a mass in the hilum. I gave you a centrally located mass. 24-hour urine collection reveals elevated cortisol. So we know we have hypercortisolism. ACTH level is elevated, so it's ACTH dependent. Ectopic versus pituitary adenoma. What is the best confirmatory test for this presentation? Well, many students do pick the chest CT scan. The chest CT scan is how you would evaluate a pulmonary mass, but unfortunately that's the wrong answer. They aren't asking you how to work up the mass, they're asking you how to diagnose Cushing's. This patient needs a functional assessment. That is, the high-dose dexamethasone suppression test. And one more before moving on. This is the same patient, but now they've had the high-dose dexamethasone suppression test, and they want you to interpret the result. Well, based on our discussion, you know the answer. But without understanding the dexamethasone suppression test, all these choices would be tempting. A pituitary adenoma will have high cortisol, high ACTH, but they will suppress. An adrenal adenoma and exogenous glucocorticoids would have low ACTH. Addison's would be low cortisol, high ACTH. The answer to this question is bronchogenic carcinoma. I called it bronchogenic carcinoma instead of small cell carcinoma because they like to use that term to mess you up. So small cell has the best derivatives for the NBME. It isn't enough to know the associations. You need to be able to work through the derivatives and understand them in their appropriate context. On to squamous cell, which also has some derivatives, but they are pretty straightforward. Its central location and associated with smoking won't help. Male predominance doesn't help. The tendency to obstruct and cavitate does help. The tumor grows big. It grows bulky. It obstructs regional structures like airways. It outgrows its blood supply. What happens when you outgrow your blood supply? You necrose. This is manifested as central necrosis. And what is the result of central necrosis? You guessed it, cavitation. Plus, it's written right here on the slide with a big old arrow. I'm too good to you guys. These are both key distinguishing features, as we will review. Insofar as the pathology, it is a classic description and applies to squamous cell cancers, including skin and esophagus. Keratin. Squamous cells make keratin. Keratin pearls is the pathognomonic feature. When they tell you that or point to one on a slide, they are telling you the patient has squamous cell carcinoma. That's how the NBME communicates. Squamous cell cancer is also described with intercellular bridges, which are simply desmosomes or tight junctions that appear as refractile striations. The cells themselves are described as polygonal with eosinophilic cytoplasm. As for the paraneoplastic syndrome, hypercalcemia is the major player. It is not enough, however, to know that hypercalcemia is associated with squamous cell. Please note the mechanism. As we will review in endocrine, there are multiple causes for hypercalcemia, and even within the neoplastic etiologies, there are multiple mechanisms. So do be aware that squamous cell carcinoma is associated with production of parathyroid-related protein. So let's again look at how squamous cell carcinoma distinguishes itself from the pack. We have a smoker with a cavitary lesion. What would be the most likely diagnosis or pathologic finding? Keratin pearls and intercellular bridges. So we have the smoker with a cavitary lesion, i.e. squamous cell, is most likely to demonstrate which of the following paraneoplastic syndromes. Hyponatremia, as in SIADH, is small cell. Hypokalemia, ectopic ACTH. Metabolic alkalosis, ectopic ACTH. Hyperglycemia, ectopic ACTH. Hypercalcemia. That is the paraneoplastic syndrome associated with squamous cell. The clue was the cavitary lesion. Now we have the cavity in a patient with hypercalcemia. They want the mechanism. All the choices listed can give you hypercalcemia. You need to do the math. A smoker with a cavitary lesion, they're telling you lung cancer, has high calcium, they're telling you squamous cell. You just have to tell them how the calcium became elevated. Parathyroid-related protein, that is, ectopic hormone production. I love this game that they play. Try as they may, the possibilities are finite, and you are smart, and there are only so many ways they can come after you. So that was squamous cell. 4 key points here with lots of derivatives and a finite number of ways to deceive and distort. Let's move on to adenocarcinoma. Note in the title the presence of the KRAS mutation. That's an activating mutation involved in the regulation of cell division. As for the key background, let me remind you this is the most common primary tumor of the lung, excluding metastatic disease. But here comes the big stuff. Peripheral location doesn't excite me, but association with scar is key and a great source of tomfoolery for the NBME. Adenocarcinoma that grows in proximity to a scar is called scar carcinoma. Think about how the NBME can play this. They'll confuse you with a million facts about conditions that led to that scar, such as radiation infection or pulmonary fibrosis. But then comes the bait and switch. They morph the question into a lung cancer question, and you never saw it coming. Be familiar with scar carcinoma. The other key piece of background information is the weaker smoking association. So they'll describe a lung cancer scenario, but your defining clue will be the absence of smoking. If they are coming after you with a lung cancer, but the patient is a non-smoker, assume adenocarcinoma unless compelling information is given to the contrary. Don't get confused by this, as the majority of adenocarcinoma is still smoking related. It's just a weaker association. The pathology is pretty ill-descript, describing glandular structures that may include the description of mucin. Not particularly exciting. Fortunately, there is only one paraneoplastic syndrome, hypertrophic osteoarthropathy. Most students are infinitely familiar with this association. However, they won't recognize the clinical description if it hit them in the eye. So let's drive this one home. Let's start with a definition. What is hypertrophic osteoarthropathy? It represents an advanced stage of clubbing with painful periosteal proliferation of long and/or tubular bones, especially the digits. And while we're in the neighborhood, what is clubbing? Clubbing is a physical exam finding of unknown cause. There are a number of disease associations, including lung cancer, lung disease, and cyanotic heart diseases, but these are not the causes. They're simply associations. And here is a radiograph of the condition, which demonstrates the periosteal reaction. You can faintly see thickening of the periosteum on the radiograph. The other key point to note, this is one of 3 or 4 conditions where the word periosteum is even used. You will hear about the periosteum with sarcoma. Osteosarcoma may be described with a lifting of the periosteum forming Codman's triangle. Osteomyelitis in a kid can extend along the growth plate, causing periosteal lifting. And finally, hyperparathyroidism is associated with subperiosteal bone resorption. So if they even talk about the periosteum in a patient that smells like lung cancer, they are describing hypertrophic osteoarthropathy and thereby a manifestation of adenocarcinoma. As for the clinical features, the description will include hand pain and probably clubbing, in addition to the periosteal reaction seen on the radiograph. And here's how they'll do it. A longtime smoker presents with dyspnea and forearm or hand pain. A radiograph reveals marked periosteal new bone formation. What is his likely diagnosis? This is hypertrophic osteoarthropathy occurring in a smoker. The diagnosis is adenocarcinoma. How else can they do it? We have a woman who's a non-smoker and a chest x-ray that reveals a single nodule. Not multiple nodules, so this isn't metastatic disease such as breast cancer in a woman. What is the most likely diagnosis and/or pathology? This is adenocarcinoma with mucin-containing glandular structures. What about the next patient? They have some symptoms of a pulmonary condition such as old TB, radiation, idiopathic pulmonary fibrosis that cause scarring. They are now noted with nodular growth in the region of prior scar. If a biopsy is performed, what pathology is noted? Answer, adenocarcinoma, that I call scar carcinoma for emphasis. And that's how they play the adenocarcinoma game. And that is adeno, completely different and completely distinguishable from small cell and squamous cell. And here is a quick infomercial on what was formerly called bronchial-alveolar carcinoma, but now classified mercifully as adenocarcinoma in situ. That makes our job so much easier. So here's the quick and dirty. First, this also has a poor association with tobacco, but don't be deceived. Adenocarcinoma is way more common. They'll come after you on this one. Secondly, it can present as a diffuse infiltrate on chest x-ray. This is entirely consistent with the pathologic growth pattern. So what is the characteristic pathologic description? Dysplastic columnar cells growing along the alveolar septum, extending to the periphery. This growth along the alveolar septum creates that infiltrative-like appearance on the chest x-ray. You will also need to note the absence of vascular or stromal invasion. Although this tumor is not frequently tested, it is this obscure or esoteric fact that they will use. columnar cells extending toward the periphery with no evidence of vascular or stromal invasion. This is bronchiolo-alveolar carcinoma or adenocarcinoma in situ. And look what I just did. I enlarged the previous slide and I'm repeating the pathologic description. I'm doing this because it's either going to be the substance of one question or it's going to appear as a pathologic distractor. There's no reason to miss this one. On the path specimen, you could just about see it growing along the septum, and this ties in nicely with the infiltrate on the chest x-ray. And that was a quick tour of the small cell and non-small cell tumors you were going to see on the boards. We reviewed the language and perineoplastic syndromes. Let's finish up with the complications and bronchial carcinoid, and then we're out of here. So SVC syndrome, pretty straightforward if you have it on the brain. Lung cancer, also called bronchogenic, is number 1, and lymphoma is number 2. They will describe either. Please note, however, in some instances they will describe a patient with superior vena cava syndrome, and you'll nail the hell out of it, but you can't find it listed in the options. What's up with that? You can't find it because they called it a mediastinal mass. They're simply ridiculous. Listed are the symptoms including cough, face and or arm swelling, and dilated veins. These are easy to reconcile. Be on the lookout, however, for the less obvious symptoms. The smoker who is described as dizzy or who might have headache and or vague visual symptoms. This is how they try to camouflage the presentation. Don't fall for it. So here it is. Patient presents with facial plethora, headache, dizzy, visual symptoms, and dilated veins. You know this is SVC syndrome. You're proud of yourself. You look for bronchogenic carcinoma or lymphoma. They aren't listed. You develop facial plethora, visual symptoms, and dizziness, but then you remember Sachs told you to look for mediastinal mass, and you nail this one. And there it is. This CT is a nice gentleman of mine with non-Hodgkin's lymphoma. He received chemotherapy and radiation therapy, and this thing is gone completely. He is doing great, but I can't get him to cut down on his rice and beans. Let's do the Pankos tumor, which is actually the dude's name, which means it isn't descriptive. So the other name is superior sulcus syndrome, and that is descriptive. The tumor sits in the sulcus formed adjacent to the subclavian vessels. The superior margin is limited by the first rib, creating a crowded space and thereby potential for lots of mischief. There are 2 syndromes to be familiar with. The first is Horner's. That results from invasion of the cervical plexus. Symptoms of ptosis, meiosis, and anhidrosis have been recited for decades. The NBME knows that you know that, so they test you on the second syndrome, which is actually more common. The second syndrome involves invasion of the brachial plexus. These patients present with shoulder pain, weakness, and or numbness in the ulnar distribution, including C8, T1 nerve roots. Any smoker coming in with shoulder pain should probably buy a shoulder film, if not a chest x-ray as well. Historically, squamous cell was most common cause, but given the overall incidence of adenocarcinoma, the 2 are seen in equal frequency. So much for the central versus peripheral locations. And here is a radiograph on a patient I recently saw. They were a smoker with shoulder pain. It would have been easy to call this arthritis or rotator cuff disease and skip the film. Whereas this isn't a Pankos tumor, it did turn out to be metastatic adenocarcinoma. I just want to get shoulder pain radiating down the arm onto your radar screen as a potential manifestation of lung cancer, and this is a means how they will present Pankos tumor to you. And just a couple of retread slides from the plural lecture. This is a reminder that pulmonary neoplasms can present with exudative or chylous effusions. FYI, this patient presented with a pneumonia and a fusion that failed to improve. He was a non-smoker. Guess what kind of tumor he had? Adenocarcinoma. And the final complication of lung cancer for this presentation is traction atelectasis. A mass in the main stem bronchus causes obstruction with atelectasis and lung collapse. This is not a pneumothorax. The collapsed segments literally pull the trachea to the affected side. This was discussed in the pleural disorder section and should only serve as a reminder. So let's finish this section with a quick review of bronchial carcinoid. Carcinoid is a PISA showing up in GI as well as cardiology. In this section, we'll focus on the pulmonary characteristics for the NBME. I think you can all recognize this as a low-grade neuroendocrine tumor. As such, you'll recognize the presence of dense core granules on electron microscopy. Those granules are serotonin containing, but they also stain positive for chromogranin. You should be familiar with the histologic description, which is the same as in GI. There are packets or nests of cells with little cytoplasm separated by a delicate fibrovascular stroma. That delicate fibrovascular stroma explains one of the key pulmonary presentations, hemoptysis. These patients may present with carcinoid syndrome, including flushing and wheezing. Whereas this is uncommon since the pulmonary vascular bed can metabolize serotonin, it is hard for the MBME to give a carcinoid question without these symptoms. For bronchial carcinoid, recall that the pulmonary circulation dumps primarily into the pulmonary artery, with only a small fraction draining into the pulmonary vein. Thus, bronchial carcinoid would need to dump into the pulmonary vein to cause symptoms of carcinoid syndrome. So here is the other big ticket item. On diagnostic studies, it is described as a polypoid growth lined by intact epithelium. So when I stumbled on this little gem, I thought it was one of those things that just needed to be memorized. But the fact is, and I skipped mentioning it with the pathology for effect, this is an intramural or submucosal mass. Right, as an intramural mass, of course the epithelium should be intact. Be familiar with this description. This is how they come after you. Polypoid mass with intact epithelium. Bingo, that's bronchial carcinoid. It makes sense. Look what I did. I'm showing you that polypoid growth with the intact epithelium. I'm so freaking annoying. And here's the pathology. Uniform bland cells with central nuclei and prominent vasculature. And that's bronchial carcinoid. We'll hear more about carcinoid in GI and cardiology. I'll bet you can't wait. And that, my friends, is how you need to learn pulmonary neoplasms. If you can appreciate the tumor language, how the paraneoplastic syndromes will be described, and have an awareness of the complications, these should be guaranteed money at the big show. If you have any questions or concerns, please email me at 12DaysinMarch. Thank you.